Good morning. First of all, I want to thank Invest in ME for inviting me. And I'm very flattered to be asked to talk to this, to you. I'll start telling a little bit about the history of what's been going on in Norway. And then I'll talk about our interdisciplinary outpatient clinic, and then about the ambulant team for patients with severe ME, and our proposed inpatient unit, which is just, well, it's very new. So, yeah, to start with. I have to thank the Norwegian patient organizations because they have been talking to politicians for many years to heighten political awareness of ME and the problems patients are facing. ME has been a very unknown diagnosis for most Norwegian physicians for many years. And I think first after 2000 sometimes the awareness slowly heightened. So when I had my first ME patient in 1997, I had no clue what was wrong with her. She was getting an acute vertigo and getting worse and worse. And after a while, the main problem wasn't the vertigo, but fatigue. And it was provoked by any type of activity. So after 2 years sending her to different specialists, I suddenly thought about something I had heard when I was studying called post-viral fatigue syndrome. And then I suddenly got a clue on what this could be. And after that, I've seen lots of ME patients. At that time, I was a GP. I've been working as a GP until last summer. So after the work of patient organization, then in June 2006, there came a report from the Norwegian Knowledge Center for Health Services with the title Diagnostics and Treatment of Chronic Fatigue Syndrome, Myalgic Encephalopathy. And that report was based on published articles, and they had very distinct ways of selecting the articles they meant were good enough. So a lot of the biomedical research wasn't taken into that report. But anyway, it heightened the awareness about the disease, and it gave it, it acknowledged that it was a somatic disease, even if some people try to claim it's something psychiatric. In March 2007, the Norwegian Directorate of Health published the report Social and Health Services for Patients with Chronic Fatigue Syndrome, Myalgic encephalopathy, encephalomyelitis, challenges and undertakings. And in that report, they outlined that they wanted Ullevål Hospital to establish a service for adult patients. They also mentioned in that report they wanted to have an inpatient unit for up to 10 patients, and now we're slowly getting there. Patients' organizations have been asking the Eastern Norway Regional Health Authorities, it's shorted down in Norway as Health East, about healthcare services for ME patients for many years. And Dr. Brubak, who was beside, we had in Norway, we had 2 doctors who have been working with that and acknowledging ME as a somatic disease since about late 80s. And that was Professor Nyland, who has been talking here earlier, and Dr. Brubak, who was the head of the infectious disease department at Ullevål University Hospital. So these 2 doctors were the 2 doctors in Norway who took ME seriously. Anyway, he was asked in 2004 and 2005 to have a closer look at the needs of ME patients, and he had so much work to do, he had no time for that. So in 2006, there was a possibility to employ a GP at the hospital 1 day a week to look at communication between primary health care and hospital services. So he used that possibility to employ me to look at what could we do to give a better service to ME patients. So he loaded me with lots of papers on research and biomedical research and so on. And he had, at Ullevål, we had a group who had been developing a coping course for ME patients that was initiated by 2 patients taking contact with Dr. Bruback, asking, couldn't we do something for that patient group and make a coping course? I'm going to talk about that course later. Anyway, they started working on that in 2003. Anyway, I learned a lot of the people teaching that and of the patient representatives as well. And then I started kind of working out what should we do to give a good service to this patient group. The problem is that most doctors, both in the Department for Infectious Diseases and Department for Neurology, they don't want to deal with ME patients because they think it's very difficult to find out what it is. And yeah, they just don't like working with it. So we found out we would, if we want to do something effectively, we would have to make a special clinic for that patient group. So that autumn I was asked to make a kind of proposal in a 2 weeks kind of, I got 2 weeks from the director of the hospital to make a proposal and kind of budget. So I set up something out of everything I had been looking at and then sent it. And then we didn't hear anything from the health authorities until January 2008. Suddenly we got money we had asked for in 2006. Anyway, it was less than in 2007 we had been working on that, on the proposal, and it had been growing. So anyway, we got started in December last year. So who's working at the ME/CFS Center? We have senior physicians, and just now we don't have enough staff. So we have the money to have more doctors, but we don't have the possibility to employ them because no other wards or no other departments in the hospital want to give away their, I don't know how you call it. You know, in Norway we have to share doctors between the whole country, and we have enough in southern Norway. So we have to apply to be allowed to employ more doctors. It's very difficult. We get the money, but we don't get the doctors. Anyway, today we have Dr. Bruback, who has retired from his job at the infectious disease department. He works for us 2 days a week. Then we had for a while a neurologist 1 day a week, and we look for a new one. He's just stopped working because, yeah, not because of ME, but because of private reasons. And then it's me working 4 days a week, and I have had a lot of administrative work, but I try to work 1 to 1.5 day weeks with patients. We also want to have a psychologist or psychiatrist to help us with differential diagnosis, because sometimes it's very hard to distinguish between ME/CFS and some psychiatric disorders, especially if we have very severely ill patients. So we need some specialists to help us sometimes to distinguish what's what here. We have a great interdisciplinary staff, a full-time occupational therapist who has been doing research, and she is doing another project now and applying for a 3rd project at this time. We have a physiotherapist who's working half-time. We have a social worker 1 day a week, dietist 1.5 days a week, and psychiatric nurse. We want to have to help people coping and so on, but that we haven't got that yet. We try to refer the patient to the most relevant specialist for their dominating symptoms. So if the neurological symptoms dominate, we have the neurologist examine them, and if the more immunologic infectious symptoms dominate, we try to have the infectious disease specialist examining them first. But anyway, they follow the same procedure, and we follow the, we look at the Canadian definition, so we get symptoms from all groups, so we don't give the diagnosis too easily. We do a lot of tests. We test for serological for a lot of infectious diseases, a lot of them who have been mentioned here earlier. We don't find a lot. We find something, then we try to treat them. And sometimes if we have indications that there could be something, we send PCRs, but we don't do that as a routine now. But we send some PCRs. we refer to other relevant specialists if we think there's might be some other pathology explaining the symptom picture. Then we refer them to the interdisciplinary rehabilitation team if needed. If they cope well and they kind of know how to deal with things, they not always want that. But most patients are referred to the occupational therapist and some of the others. We recommend if they have sleep most have sleep problems, so we discuss a bit with them, but usually we let the GPs prescribe medicines to lighten their symptoms, but the GPs can call us and then we can discuss what to do, like melatonin or other possibilities to ease that. And most of them are referred to the coping course that has been going on since 2004. So what do they learn when they are sent to interdisciplinary rehabilitation? They are taught pacing, energy conservation. Our occupational therapist is very good in kind of telling them techniques to do daily activities with less use of energy, so they can use their energy for something else. The physiotherapist is talking about how to achieve a balance between activity and rest, like what are your signaling symptoms that you slow down now, and so on. And she's teaching active relaxation, because many ME patients experience that if they try to rest, the system is going like on high gear, you know, they can't relax properly. And if they learn these techniques, they often get a better rest when they're resting. They get dietary advice, and those with food intolerances are helped to find out what to do about them. And they can just discuss social security problems and community-based services with our social worker. They can't go to all of these people more than maximum 2 times because we don't have the capacity. So the team helps them to get in contact with similar or with other occupational therapists and so on at the community-based services, and talk to them and tell them what to do about them. So we hope to heighten competence in the primary healthcare system so they can deal with these patients and give them good advice and not kind of bad advice like overtraining and so on, what has been usual. Then we have that ambulant team, and the mandate of the ambulant team is to ensure that homebound patients are diagnosed. Not all patients who have so severe ME that they are unable to get out of their bed and out of their home are properly diagnosed, and some are too ill to be diagnosed. Sometimes we can just go and have a look with them and then maybe ask some words and touch them, but sometimes they are so ill you couldn't do a proper diagnosis. But anyway, some of them are homebound and can be diagnosed at home, but they wouldn't be able to talk if we would get them to the outpatient clinic. Anyway, the mandate is to give those with ME confirmed diagnosis and to make sure those where we suspect anything else are referred to a relevant specialist. Patients with ME who are homebound can get help by the interdisciplinary team, and we can visit them. The community-based services we have to help them that community-based services are established. Sometimes only the family is caring for them and they are totally exhausted. And primary healthcare practitioners who are in contact with these patients are offered coaching by the team. So we offer up to 5 visits per patient, 1 or 2 relevant professionals each time, medical examination by a physician, relevant professionals teach patient, if that's possible, or relatives and or caregivers about the condition, and different coping techniques as mentioned for the outpatient clinics, but at a different level, of course. Up to 2 members of the team can attend a meeting with representatives from primary care community-based services and to ensure patients get necessary help. In Norway, we have something called individual plan, which is for patients who are in need of complex services. That means they are in need of more than one service from the community-based services. And if they have an individual plan, that is to be approved by the patient or relative if the patient is too ill to do that themselves. And the community is kind of, they have to agree on that plan. And what they have agreed on that plan is a right for the patient to receive. So if the community says, we can give you this and that kind of home nursing, so many hours, or personal assistant, or whatever, then they are obliged to follow it if that's written down in that plan and agreed on. We are there to give advice to professionals working in primary care who have questions about own patients suffering from ME. We don't have the capacity to have a patient phone, but there is one place in Norway where they have got money to try a model of a patient phone line where patients can call for advice, and it was meant to be locally, but it's used from the whole country, and I hope they get the money to continue with that, because we try to say, okay, we can give you doctor advice, or we can give you occupational therapist advice, but we can't give every patient advice because we just don't have the capacity. So general practitioners are calling. Very often also psychologists call me because they say, well, I've got to refer to an ME patient, but there's nothing I can do psychologically. I think, or I've got to refer to a patient, I think it's ME, and so on, and we can discuss the patient and so on. District nurses can call other healthcare professionals in the community-based services like occupational therapists, physiotherapists, and so on. Nursing homes, we have some severely ill ME patients living in nursing homes, and some of the referrals to the ambulant team are from nursing homes. And then often they ask us about the care to give, because often there's a big conflict in what ME patients or their family expect in care, in noise protection, light protection, and so on, and what the nursing homes feel they can give them. So we feel that one sort of the requests on ambulatory team is to help them kind of mediate between these two parts to find a solution both can live with. And from Social Security, which is, I'll try to write it down. Well, it's the authorities in Norway who give money to people who can't work anymore. They get sick leave money for 1 year, and then it's a bit more difficult to get money. And sometimes they call us, and I give them advice. And I've been able to talk to the doctors looking at the papers from patients a couple of times, so making them aware that you can't put people to work practice, kind of, they want to try out what work ability they have left, and many patients get much worse through that process. So I've tried to tell them you can't do that with ME patients before they're on a stable and getting better. Our coping course, it's once a week for 8 weeks. They have 1 week break in the middle, and so it's 4 weeks, 1 week off, and 4 other weeks. And for some patients, it's what they can do that week is that course. Some patients are a bit better functioning, but anyway, it's only for patients with light or moderate ME. It's 2 hours, including a 30 minutes break with possibility for guided relaxation. A patient representative talks about own experiences with ME. She's sitting here in the front row. And she's one of the patients who took contact with Dr. Brubach in 2003 to establish this course. Then I'm talking to the patients about what is ME and about all the weird symptoms and a bit of pacing and stuff like that. And what we see at that course is that many ME patients see, oh, I'm not the only one experiencing all these strange and weird symptoms. They think they're very, very special and everything. They haven't heard of anybody having symptoms like that because it's a weird combination and nobody finds anything. But when they come here, they see it's common for this disease. It's not so special, and that makes the situation a little bit easier for them. Then we have a psychiatric nurse or counselor, you would call it here, I think, to talk about how to cope with ME and have a discussion with the patients. And we see that patients have a lot of guilt in not functioning well enough, in not giving enough to the family, and not working, and so on and so on. So there's a lot to talk about. And also the other days, it's coming up all the time, how much guilt they feel of not being able to do what they think they should. Then our physiotherapist talks about balance between activity and rest, and how to find your kind of signaling symptoms. Our dietist talks about nutrition, and the occupational therapist talks again about pacing and energy conservation methods, and also kind of practical aids. What things could you get to make activities easier? And then our social worker talks about social security issues and stuff like that. And the last day we have again the first hour with a psychiatric nurse, because the patients asked for that. And then a summarizing panel where all who have been talking there answer questions from the patients. So, in March this year, we were asked by the Southeastern Norway Regional Health Authority to investigate the establishment of a national inpatient unit. So, from 2007 until now, it took until they asked us to look at that. Anyway, we had the letter at our place at March 3rd, and they wanted an answer on how we want to do this and what the costs are until the 30th of April. So we had very little time. But anyway, we had been thinking about a lot of things from before, and we established a group with two patient representatives, one who had been severely ill from ME and has become better, and one who has 3 children with severe ME and who knows most of the severe ME patients in Norway from her work in the patient organization. She's here as well. And well, in that letter from the health authorities, I quote, they wrote, "There's a minor number of patients with CFS-ME who are severely and prolonged suffering and in need of adequate medical examination and treatment. These patients need a protected environment and staff with special qualifications for nursing and treatment of this target group." So they have understood something, anyway. And I think that's very much the work of the patient organization, that they were able to communicate how severely ill ME patients are. So what is a ME patient with severe or very severe ME? Usually it's a bedbound patient in need of care. They are sensitive, usually they're sensitive to noise, light, smell, and some even touch. They're in need of help for personal care and hygiene, but sometimes even that will be too painful or exhausting for them. Some are in need of feeding because it's too exhausting to eat themselves, and some need tube feeding, and we even had people on VAP, have people on VAP in Norway. So they are certainly unable to come to clinic for medical examination. And some will be too ill to be moved from home. That means this is not a service for the really very, very severe ME patients. And I think it's impossible to make something for this patient group because you just can't get them, transport them. They wanted us to cover both examination and treatment. So one aspect of the service is medical examination if not all other diseases are excluded before submission, and the other aspect is treatment. And what we can offer today, apart from kind of, helping them sleep and helping them doing something about their pain and treat infections if we find some, is teaching them, as we do at the coping course, pacing, like, well, if you feel for moving, do move, but don't overdo it. Learn your limitations. Active relaxation, also in that group, they are lying in their bed all day, but they don't relax very often. So if they are well enough to take instructions, then we can do something. If they're not well enough for that, we couldn't have them. They can have dietary advice, and sometimes it's only to cope with the challenges in caregiving, like prevention of ulcers and joint problems. But before treatment is possible, it is necessary to examine if the patient is in a stage of the disease where active approach will not cause an aggravation and improvement is possible. Like some patients wouldn't be able to take, to listen to instructions or anything, and then we can't approach them. So if they're so ill, we wouldn't be able to help them at that service. So how are we going to do that? We found out we are in a very old building of a very old hospital. It's a hospital that's about 100 years old and with really large rooms. So the rooms were earlier occupied by 4 to 8 patients, now really huge rooms. So the 8 patients, or I think 4, 8, 11, 9, 10 patients is the biggest room. So from that room we are going to make 3 rooms, and then we have a hall before you come into the rooms, and then we have 2 bathrooms which 3 patients share. So anyway, we managed to put in there 8 single rooms with ensuite bathroom, or they have to go out in the hall and then to the bathroom. It's also good because otherwise you would get a lot of noise through the door, so they have 2 doors between the patient room and the bathroom. We are going to put in insulation to protect from noise, and they have that hall in between. There is possibility for light protection in different stages, like shutting out every light or letting in a little bit. And we have been demanding dimming lights on all lights, so it's not like on and off, everything is possible to get more or less. Then we have 2 sitting rooms, because when the patients get a little bit better and want to go out of their room, because it's very important for them when they're able to come out of the room. We have 1 room which is a quiet room, so you shouldn't talk, so you can just sit there and enjoy not being at your own room. And then the other room would be with a TV and possibility to have guests visiting you and talking. And then we have a little balcony which we want to upgrade, so we can go out there with patients in a wheelchair, so they can get some in touch with light and weather if they're able to. We have space for 2 treatment rooms, 1 for the physiotherapist and 1 for the occupational therapist, also for patients who are able to get out, and maybe we'll use that a little bit for the outpatient clinic, which is in the same level of the building, like having groups, relaxation groups or stuff like that at the physiotherapist room. So how would we staff that? We need 1 leader to coordinate everything. We have come down that we need 14 nurses or nursing assistants to be able to kind of cover up for all days and weekends. So we'll have at least three nursing staff daytime and 2 afternoon, 2 night. We need 1.5 senior physicians there, but we want to put it in 3 different categories. We want to have a neurologist, we want to have a specialist in infectious diseases, and we want to have a psychiatrist, because especially in that group it's very important to rule out any psychiatric condition that could give similar symptoms. We want to have 100% occupational therapist, a physiotherapist, and 1 assistant for these 2 to help them kind of train or, do things with patients, for the physiotherapist, like contracture prevention and stuff like that. We're going to have half a dietist, and then we have something called in Norway which is called a ward host, which is a person at the ward who is preparing food to people when they on demand. Like, the hospital kitchen gives you food at 8 and 12 and 5 or something like that, and the ward host could take certain food that is on the ward and prepare it for people on demand. That is only daytime, so in the evening the nursing staff has to do that. But anyway, we are going to have a proper kitchen which is kind of, with all the needed things to be able to make our own food. And we also are allowed to borrow a diet chef from the hospital kitchen who's going to be there daytime on work days, so we can prepare some special food for people with food intolerances, and then we can have it in the fridge, and in the weekends and evenings and night the nursing staff can warm it up and give it to patients. And we want to have one 0.5 social worker and one secretary. So the proposal outlines a highly specialized inpatient unit for medical examination and treatment of patients with severe ME. Localities are designed to suit ME patients' special needs. Staff especially interested in and trained for working with this patient group is employed. Limitations are some patients with very severe ME will be so ill that they will not tolerate to be moved or touched as much as needed for admission and medical examination. The proposal was sent to the Southeastern Health Authority by April 30th. It's recommended by the first level. I got that confirmed 2 days ago. It has to be approved by the leader conference of the health authority. Then it has to be approved by the Norwegian Health Department to get the money on the budget for next year. I was told that they should have known the sum of that in December last year, but they'll try to change it. So everything is open, but the political will to do something for that patient group is that big that we think we'll get the money to start it. And after approval, we need minimum of 4 months to change existing rooms and employ staff. So that's what I have to say today. Thank you.
Thank you for the recognition of how severe this illness can be. You mentioned the exhaustion of the carer, and when you unpacked the roles that your unit was going to use, it becomes obvious why the carer, who's trying to be the nurse, the physician, the ward specialist, the dietitian, the social worker, the physiologist, and so forth, is so exhausted. Are there any programs as ancillary to your model to provide care for the carers or support for the carers who are the invisible part of this illness, who are in the blind spot? I describe myself as having carers' dementia. It begins to become, you start to share the brain fog because you share the physical exhaustion of your patient after a while. My experience is that there's simply nothing there to support the people who are carrying, trying to nurse, trying to care for the people with this wretched illness.
For the professional carers, we are going to establish coaching groups, and when we see people in nursing homes, we also recommend to have a coaching group so they get support and don't get exhausted, and kind of have one place where they can kind of get out their frustrations and get backed up that they are doing a good job, because sometimes you feel whatever I do is wrong. But we don't have a special program for relatives now. So if caring relatives are kind of not taken care of by this stage. But yeah, I'll take it back.
And there was one other question that's been sent in, which is of enormous interest to me, and I think many doctors treating ME. Is there a list of patients who are understanding of ME and wish to treat them? And if there are, would it not be better to have a protocol for the investigation and management of these patients, which is more or less agreed, so that people with rather extreme views don't get to pursue one particular angle and not the others? So I think a conceptual view of what is agreed as reasonable investigations and reasonable management. And I speak with a huge prejudice, because I happen to think that diet and nutrition and trace elements are very important, and as are the gut bacteria, or abnormalities in gut bacteria. But then my students would say, well, I would think that, wouldn't I?
I'd like to ask Dr. Baumgarten about the unit and its intent. Is it one that will be a respite unit, or will it be to bring about change? And if it is to bring about change, will there be a time limit on the time that patients spend in that unit?
One part is the diagnostic part for people who aren't able to come and go to different examinations. The other part is, well, we'll try to give them a kind of coping course and start to see how they can manage their disease better in that unit. And I think we'll have stays of about 3 months first, and maybe then another 3 months, and so on. But we have to test out that. We don't have kind of fixed time limits to, because it's going as a project, like our outpatient clinic now, it's a kind of project, so we can learn as we go. So I'm not sure either if we can contribute very much to the severe ill ME patients, but since it's a political wish to do something, I think we'll try. And on the other hand, we have a very good material in that, both in the outpatient clinic, ambulatory team, and with the unit, to do research. And we are looking in different directions, like looking at genetic research, looking at viral research, but we haven't landed on what and how to do, but we are kind of collecting information and trying to find out which kind of kits could we use and so on to get some more materials, because we have 75% patients referred to the outpatient clinic every month, so we have a big material of patients.